Dear friends, I'm Dr. Ankur. Today, I am going to discuss about antenatal steroids. This is a very important topic for all the neonatologists and obstetricians because this is one of the most important interventions which would ultimately, prevent the prematurity and prematurity related complications. So that's why it's very important to discuss about that and what are the recent updates about antenatal steroids. Today, I'm planning to discuss about mainly when not to advise and why. The main objective of today's discussion would be what is the indications where it's going to be high likely to benefit with a great evidence. What is the role in the late preterm, that is 34 to 36 weeks gestational age? What are the roles before elective cesarean sections? Can we repeat it? What are the long-term outcome, whether it's going to harm or it's going to benefit the baby in long-term status, and which type of steroids and what dose of antenatal steroids we should use. Uh, if you look at the antenatal steroids, it has been one of the most important advances in the perinatal care. It was first used by Liggins in the year 1972, and if you look at the history closely, and when he did a study, uh, it was denied by the Lancet to publish their study in their journal. Ultimately, they got published in 1972, but it took almost 20 years to get a meta-analysis by Cochrane in 1994, and after that it was accepted universally everywhere, and the forest chart was adopted by the Cochrane database, and that's why these forest charts are we see in the Cochrane database that is actually came from the meta-analysis of antenatal corticosteroids. Looking at this chart that included 30 studies, almost 8,000 plus infants that included between 22 to 34 weeks of gestational age, where they have found that antenatal corticosteroids led to the reductions in the various outcomes, but they affect during the first 7 days after giving after the completions of antenatal corticosteroids, and the outcomes are perinatal death, neonatal death, respiratory distress syndromes, intraventricular hemorrhage, developmental delay. So I have color coded it. Color coded means the green one. Green means the antenatal corticosteroid is going to benefit. High likely to get benefited. Yellow means only likely, and the first look at the perinatal death, the reduction was 15%. If you look at the number needed to treat, it is 43.5 with a confidence interval of 27.8 to 100. Neonatal death, 22% reductions with number needed to treat 38.5. That is confidence interval is 27.8 to 62.5. Respiratory distress syndrome, 30% reductions with number needed to treat 23.3 with a narrow confidence interval. Intraventricular hemorrhage, 42% reductions with number needed to treat 71.4 with a slightly wider confidence interval that is between 55 to 125. Developmental delay, 49% reductions with a number needed to treat is 27, obviously with a very long confidence interval between 17 to 500. And this was recommended by the RCOG in 2022. So I have color coded uh, in red also. That means these two outcomes, that is the IVH and the perinatal death, would be affected during the first 48 hours after the completion of steroids. The effect does not last beyond 48 hours. So if you look at the all bodies recommendations, WHO, Ministry of Health and Family Welfare, ACOG, and RCOG have recommended to use antenatal corticosteroids between 22 to 34 weeks of gestational age. What are the durability of benefit? So as I have told that the IVH and the perinatal death would be affected by these steroids, antenatal steroids, during the first 48 hours. That means if you have given the steroids and the patient has I mean, continued the pregnancy beyond 48 hours, it's not going to affect the intraventricular hemorrhage or the prenatal death outcome. However, the effect on the respiratory distress would last up to 7 days. So we have to consider, we have to counsel the parents before giving the antenatal steroids, and we should always discuss with the obstetricians. I mean, if it is, I mean, if the patient is going to deliver within the first 7 days after giving a steroid, then we should consider for giving antenatal steroids. Otherwise, we should not give. So after 1972, I mean, after 20 years of meta-analysis, so the recommendations came for 24 to 34 weeks of gestational age. However, by 2005, people have found that there are certain groups of neonate, we call it a late preterm, 34 to 36 weeks. They also have this similar type of morbidities like a extreme preterm, like a infants between a 24 to 34 weeks. So in 2005, NIH gave a definitions of late preterm, early term, late term, and term, redefined this gestational age based on the various neonatal morbidities. What they found that the mainly the respiratory morbidities is variable at different gestational age. So as the gestational age is decreases from 39 to 40 weeks to 34 weeks, the incidence of RDS increases progressively. I mean, at 36 weeks, the RDS is uh, 9.1 with a confidence interval of 7.5 to 11.1. At 34 weeks, the incidence of RDS is nearly 40%. I mean, 40%. And TTNB is same. I mean, at 39 to 40 weeks, it is the lowest risk at full-term pregnancy, whereas at 34 weeks, the TTNB incidence is 14.7%. Any need of ventilation is also very high at 34 weeks, that is around 13.9 with a confidence interval of 11 to 17.5. We also did a similar type of study during the year 2008 to 2011 and published our data in the Newcon and the FABS 2012. We also found similar type of outcome looking at the respiratory morbidity at various gestation, that is 34 week, 35 weeks, 36 weeks. We have included almost 1,887 infants. We found that the incidence of respiratory distress was around 24.5%. At 34 weeks, it was 11% at 35 weeks, and at 36 weeks, it was 8.5%, whereas at 37 weeks and beyond, it was 3.2%. Need for ventilations was, I mean, nearly 38% versus at 30, I mean, at 35 week, it was 72%, depending on the number of infants. And at 36 weeks, it was around, I mean, 43%, whereas at term, need for ventilation that includes any NIV, that includes high flow, CPAP, I mean, NIV in the range of at term is around 35%. So if you look at the adjusted odds ratio, when we adjusted with other more, I mean, outcomes, the odds ratio at 34 week for any respiratory distress was 9.5 with a CI of 4.4 to 20.8%, which was statistically significant. At 35 weeks, the odds ratio was 3.7 with a narrow confidence interval. At 36 weeks, it was 2.8. It was, I mean, statistically significant. So the question came that should we expand the window of for using antenatal cortics towards upward, that is beyond 34 weeks, downwards below 24 weeks. So nearly a year at around 2016, ALPS trial camps. So what we found that ALPS is that antenatal steroids for women at risk for preterm delivery, that is late preterm delivery. I mean, what these studies have shown that if you look at the outcomes, severe respiratory complications among infants, I mean, where they received antenatal steroids, the incidence was 8.1 versus placebo. It was 12.1 and it was statistically significant. And it was almost, 33% reductions in the form of any severe respiratory distress. They have defined either use of CPAP or high flow for more than 12 hours or a FiO2 need of more than 30% beyond 24 hours of life. However, if you look at closely, the actual severe RDS incidence was there was no difference in the severe, I mean, mainly the hyaline membrane disease, that is respiratory distress syndrome. So they decreases the outcome of for milder variety, not a severe variety of respiratory distress. Need for surfactant uses was also low, where in the infants, those who received antenatal corticosteroids. And after this trial, the uses of antenatal steroids was, I mean, exponentially increased in the group late preterm and early term infants. And this was the study published by Ellis in the American Journal of Obs and Gynae in the year 2022, August. And if you look at the data, you can find that. So before 2016, antenatal corticosteroid uses were between 28 to 31 weeks was almost same before and after 2016. Antenatal corticosteroid use between 30 to 33 weeks, there was no difference. However, if you look closely, for infant born at 34 to 36 weeks, there was an exponential increase in the uses of antenatal steroids after 2016. Whereas even in the full-term infants, the steroids use was also high as compared to previous years, and that means before 2016. But if you look closely, the outcome here, the outcome I'm talking about, perinatal death, number needed to treat was 4. If you give antenatal steroids before 31 weeks, if we include 24 to 35 weeks, the number needed to treat decreases from, I mean, increases from 4 to 19 with a confidence interval of 14 to 28. And at 34 weeks and beyond 34 weeks, number needed to treat. That means to prevent one perinatal death, you have to give, I mean, steroids to 55 mothers. And I mean, before elective cesarean sections, to prevent one perinatal death, you have to give antenatal steroids to 106 mother, I mean, to prevent one perinatal death. And if you look at the confidence interval, it is very, very wide. That is 61 to 421. Obviously, we are not looking at perinatal death or neonatal death I mean, 34 and 34, beyond 34 weeks, because during this period, we are mainly looking for the respiratory morbidity, that is TTNB, mild or moderate type of respiratory distress, need for ventilations, need for oxygenations, or need for NICU stay or hospitalizations. And if you look at the current status of antenatal steroids, if you give antenatal steroids between 24 to 34 weeks, only 4% population would require during this period. I mean, overall delivery populations. If you look at the overall delivery populations, only 4% of them falling between 24 to 34 weeks. And between 34 to 36 weeks, I mean, steroids were given up to 77%, and steroids were given before elective cesarean section in the range of 10 to 60%. So that means the total potential for pregnant women exposed with antenatal corticosteroid goes from 22 to 70% in the last last I mean 8 to 10 years after 2010 or 16. And more pregnancies are being treated, which changes the benefit to risk ratio. However, many of them, if you give a steroid, they don't deliver within 7 days. So the benefit, I mean, the effect of antenatal steroids went off beyond 7 days. If you look closely, the Cochrane meta-analysis was done in 2006, that included 21 studies, 7,000 infants. They found that antenatal corticosteroids led to reduction in the neonatal death. But out of all these study, the two study which included 498 neonates, when they were followed, they found that only if they delivered before 30 weeks, there was a reduction in the range of 30%. Okay, in neonatal death. However, many of them they don't deliver before 34 weeks, they found that the death rates were high. That was in the range of 3.25 times higher death. However, there was, I mean, the confidence interval was not, I mean, it was very wide and it was not significant, but it showed that if the patient don't deliver before 34 weeks, the chances of death would be high. At the same time, the maternal infections were high in the range of 1.35 times higher if they don't deliver, before 34 weeks. So there was some, data coming from the old Cochrane meta-analysis that the risk of neonatal death, stillbirth, maternal infections would be high if the patient don't deliver within, before 34 weeks of gestation if you give steroids. Not only the short-term outcome in form of infections in the mother, like neonatal death or stillbirth, but the long-term outcome was also not good if the patient don't deliver at at or before 34 weeks. So if you look at this studies by the Pauls, which was published in the year 2007, and they found that if the patients uh, delivered at term and have not received any steroids, the long-term outcome in form of low global cognition was in the range of 15% only. If the patient had received steroid during any time between 24 to 34 weeks because of possible threatened preterm labor, if they don't delivered and they delivered beyond 34 weeks, and if the long-term outcome was bad in the range of 48%. And there could be various reasons for this, poor neurodevelopmental outcome. This could be because of the effect of anticorticosteroids. This could be because of the effect of the use of tocolysis, use of antibiotics in the mother, or maybe threatened preterm labor also. But we should understand that if you're considering for steroids for any, preterm delivery, you must think about that first, that if the patient is going to deliver within 7 days, then and then you should consider for antenatal steroid. Otherwise, you should rethink about giving antenatal steroids. At the same time, during the year 2016, anti-corticosteroid used in late preterm, they also found that the risk of hypoglycemia was very high in the range of 60%. And the risk ratio was 1.6 with a wide confidence interval. And if you look at the number needed to harm, you have to give, 10 patients to, develop one hypoglycemia in neonates. That means you need to closely monitor these infants if they have if their mother had received antenatal steroids. So number needed to harm is very low. Similarly, during the same times, three or four more studies came. They also found there was no difference in the outcome in form of respiratory morbidities or the need for ventilations. However, almost all the studies have found that the risk of hypoglycemia was high. And if you look at the adjusted odds ratio for developing hypoglycemia in all these studies, so it was in the range of 1.6 with a confidence interval of 1.24 to 2.07, depending on the gestational age. If you look at the adjusted odd ratio if the mother is having gestational diabetes, the risk of hypoglycemia is much higher. It is 5 times higher as compared to non-GDM pregnant ladies. And similarly, they also found the recent one of this study that association between maternal and antenatal corticosteroid treated and mental and behavior disorders in children. If you look at the exposed patient, the risk of harm, the harm ratio is 1.47 as compared to those who are not exposed. What are the harms? Increased rates of mental and behavioral disorders during childhood, both in entire populations, that is 12% in exposed versus 6.4% in unexposed. And the adjusted hazard ratio is 1.33 with a CI of 1.26 to 1.41. That means those patients who are already exposed to antenatal corticosteroid, the chances of, the hazard ratio in form of behavior, mental disorder would be high if they don't deliver prematurely. So among children born at term, even among children born at term, the median of 1.4 median age is 1.4 years younger than unexposed children at the time of diagnosis of mental and behavior disorder. That means, the mental and the behavior disorders, they develop early in infants where they have, their mother have received enteral corticosteroid compared to those who have not received. What is the conclusion about antenatal corticosteroid for late preterm, whether we should consider between 34 to 36 weeks or not? So, if you look at the RCOG 2022 guidelines, they have found that the benefit is only likely for mild respiratory morbidity. And we all know that the mild respiratory morbidities can be easily managed with the level 2 or level 1 NICU with a availability of nasal CPAP or heated humidified high flow oxygens. Otherwise, you need to monitor the hypoglycemia because the risk of hypoglycemia is very high in the range of 60%. And we know that the hypoglycemia can damage the brain also. That is why WHO recommends we should not offer antenatal corticosteroid between late preterm. Minister of Health and Family Welfare in India also recommend we should not consider antenatal corticosteroids between 34 to 36 weeks. However, RCOG recommends, but they recommends that first you should explain the hazards about the risk of hypoglycemia and other long-term morbidity to the parents. If they give consent, then you should consider. ACOG recommends they recommend that we should consider for giving antiplatelet steroids. However, they recommend that we should closely monitor, blood sugar in these group of infants during the first 48 hours of life. And if you look at the number needed to harm, it is very low. That is 11 with a CI of 8.8 to 14.7. If you're looking at the hypoglycemia, that means if you treat with 11 patient, you can develop, you can expect one hypoglycemia. Number needed to harm. If you're looking at psychiatric disorders, psychiatric behaviors, so the number needed to harm is 38.8 with a narrow confidence interval of 30 to 52.4. So we should not consider antenatal corticosteroid giving during these periods. Rather, we should counsel the parents. Rather we should counsel the obstetrician that we should try to avoid. The other important topic is that whether we should consider giving antinatal corticosteroids before elective planned cesarean. If you look at the guideline of 2016 by RCOG, they recommended that we should give antinatal corticosteroids during, before elective cesarean sections, but that was not based on very good, robust data. After that, the uses has increased. Like anything, but if you look at the various studies by which was done during the 2005, 15, 16, and the meta-analysis done in 2016, what they found, then the outcome, there was only a mild difference in many small differences in the outcome in form of decrease in TTNB or mild respiratory morbidities, morbidities. But when the associate reanalyzed their old data in the 2022, they actually removed the three poor studies from the analysis and they reanalyzed the data and they found that the number needed to treat is 35.7. That means it was increased. So means if you treat 35 patients and then you can get a one uncertain benefits for respiratory distress syndrome and TTNB, and the patient may benefit in NICU admission or decrease in the respiratory distress from 5.5 to 2.3, just a small difference. So but at the same time, it may reduce educational attainment at school age. So that is why WHO recommends no to, no. Ministry of Health and Family Welfare recommends no. RCOG recommends that if you want to give steroids before elective cesarean sections, explain hazards to the parents. And if they consider, they give consent, then you should consider. ACOG recommends no to before elective cesarean sections. Can we consider a single repeat course of antinatal corticosteroids? Yes, almost all body recommends that we should consider giving repeat antenatal corticosteroids, but we should, look for these things that it should be recommended for women only below 34 weeks of gestational age who have received a single course of antenatal corticosteroid at least 7 days prior. On clinical assessment, they have high likelihood of giving birth preterm in next 7 days. If you don't feel that the patient is not going to deliver within 7 days, please don't offer. Because one major concern of repeated use of antenatal corticosteroid is they are likelihood of getting a smaller baby, and the mean difference was of around 80 grams. And there are chances of, if you are giving repeated steroids, there are chances of, I mean, maybe having a small hit size and small lengths. So if you look at the recommendations, WHO recommends yes. Ministry of Health and Family Welfare India recommends we should not consider giving repeat course of antiretroviral steroids. ACOG, RCOG have recommended to use repeat antiretroviral corticosteroids. Repeat means one repeat course of antiretroviral corticosteroids. If you look at the rescue course in their efficacy, yes, they have found that they decrease the composite morbidity in the range of almost 35%, RDS almost 36% reductions, chronic lung disease reduction. There was no difference. Need for surfactant and ventilation need was also lesser 30 to 40%. And those who received, those who delivered before 34 weeks, there would be 40 to 60% reduction in less RDS surfactant used in ventilation need. But here you have to notice that 45% of this group of patients, they don't deliver before 34 weeks, and they generally delivered after 34 weeks. And we know if they delivered beyond 34 weeks, risk of neonatal death, risk of neonatal brain damage, the risk of infection in the mother is high. And what about antenatal corticosteroids for imminent periviable birth? I have taken it from the ACOG guidelines. So for 20 weeks, there is a recommendation that we should not consider because the outcome is very poor. If you are talking about Indian settings at 22 weeks, you can consider, depending on the availability of the level 3 NICU and their old outcomes. If the parents are ready, then you can consider. Otherwise we should not consider. 33 weeks at various centers, the outcomes are, nearly 20-30%. So if the center is providing level 3 care, and the parents are ready for, to continue the resuscitation effort and beyond resuscitations also, and then you should offer full obstetric care, give antidote corticosteroids, magnesium sulfate, and better to deliver the infant at that center only where all the facilities are available. And obviously beyond 24 and beyond, between 24 to 34 weeks, there is no confusion. However, if you look at the guidelines, WHO and the Ministry of Health and Family Welfare doesn't recommend giving antidote corticosteroids between these very viable birth. RCUG and ACUG recommends that we should consider for giving this. Now about something about the dexamethasone versus betamethasone acetate plus phosphate. So there are some confusion, and this is a one landmark trial. We call it a asteroid trial. It was a multicentric double-blind RCT trial, and they have included almost 679 in each group. And they looked at the outcome at 2 years of age, death, or any neurosensory disabilities. If you look at the mean gestational age, that was around 29 weeks in both the groups. And there was no difference in the death or neurosensory disability at 2 years of age. There was no statistically any significant. There was no difference in any death. There was no difference in respiratory morbidity, any serious morbidity, maternal infections, no difference in developmental growth delay and the Bayley scales, no difference in IVH, PVL, PDA, RTS, BPT. Overall, there was no difference. There was a one chance finding was that any ROP requirement treatment was high in group of betamethasone compared to dexamethasone. Obviously, this was not the primary outcome. So finding indicates that either antiretroviral corticosteroids, be it betamethasone or dexamethasone, can be given to women before preterm birth to improve infant and child health. So which and what doses of antiretroviral corticosteroids? I think both betamethasone and dexamethasones are good. Here we are talking about betamethasone combinations, that is betamethasone acetate plus phosphate. But in India, we don't have, these betnasols. In India, we have only betamethasone phosphate. Betnasols are available. But if you have the availability, both drugs are equally efficacious. The total dose would be 24 milligram. If you're using betamethasone acetate and phosphate, we should give a 12 milligram once a day for 2 days. And it was found that this betamethasone had shown that it causes less chorioamnionitis. If you're using dexamethasone phosphate 6 milligram hourly for 2 days, it was found that it shows less IVS compared to the betamethasone. In UK, there are studies. They found that the dexamethasone can be used 12 milligram once a day for 2 days. They found there was no difference in the outcome. But in India, if you're using betamethasone phosphate, we should use it like a dexamethasone phosphate. That means we should give 6 milligram or betamethasone phosphate 12 hourly for 2 days if we want to use. Otherwise, the Ministry of Health and Family Welfare strongly recommends of using dexamethasone phosphate and not the Indian betamethasone. And this is the last summary where the recent all the meta-analysis was included in this trial. And one or two studies we have added, that is ACT trial and ACTION 1 trial, where they have looked at the death as an outcome. If you look at the ACT trial, I mean, they found that number needed to harm is 293. I think in this study, the inclusion criteria was not good. There was, I mean, slightly bigger infants was there. I mean, more mature gestational age was there. And that's why they found that the stillbirth, the mortality, and the infections were higher. I mean, we can call it it was not a robust study. That's why the ACTION 1 trial was done, WHO with a robust primary outcome, and they shown the similar type of outcome as the previous studies has shown. They found that the number needed to benefit was 26 with a confidence interval. I mean the respiratory rate, the relative risk was almost 15% reduction in the neonatal death with a narrow confidence interval, that is 0.72 to 0.97. They have included objects up to more than 2,000, nearly 3,000 infants. And the one meta-analysis by McGoldrick in the year, recently published in the year 2020, they included studies from 1970 to 2010. When they included all the studies, they found that number needed to benefit to prevent one neonatal death, perinatal death, was 38. And with RR of 7.78, that is almost, I mean, 22% reductions in the neonatal death with a narrow confidence interval of 0.7, 0.87. That is why it's a grade A recommendations if you're using antenatal corticosteroids for a right gestational age, that is between 20, probably 23 to 33 plus 4 weeks, provided the patient is going to deliver within 1 week. If they are not going to deliver within 1 week, try not to offer antenatal steroids. So I'm just included this slide. Antenatal steroids has been one of the most important advances in perinatal care as a great evidence. But if you look at the history, in 1972, Liggins did, publish this study, which was initially rejected by the Lancet. They could not able to publish their studies, and it took 20 years to get a meta-analysis. And after meta-analysis, the uses was, exponential. It was an universal uses, and Cochrane adopted the forest chart for this antenatal corticosteroid, and they have shown a good brain protections. By the year 2005, NIH found that there is a one term 34 to 36 weeks that late prem. They also have various neonatal respiratory morbidities, and after ALPS trials, they found that the incidence of RDS, the need for ventilations, oxygenations, need for the CPAP and high flow were lesser in the group where the anticorticosteroids are, offered. However, when we look at the long-term data, and when we include, the ACT trial also, they found that the the mortalities, the stillbirth, the maternal sepsis, and along with long-term neonatal brain injury was also high in this particular group of infant. And by 2020, WHO action trial, including both, robust methodology, they found that if you choose a right population, that is, uh, at those mother who are at risk of preterm delivery between 23 to 33 weeks, this is going to certainly help in the perinatal outcomes. And the Cochrane meta-analysis did reanalyze the data when the RCOG gave the recommendations for using antenatal corticosteroids before elective cesarean sections. The uses of antenatal corticosteroid increase, but after excluding three poor quality studies, they have recommended that we should not consider. If when you are considering antenatal corticosteroids before elective cesarean sections, please explain the hazards to the parents, that it can lead to hypoglycemia and long-term brain damage in form of mental behavioral issues. So that is why the current recommendation is that Antenatal corticosteroids should be only used if the delivery is imminent within next 7 days. So this is the last conclusion slide. I have included this uh, I mean, the grades of recommendations, number needed to treat, and mainly the respiratory stress, and included four body, that is WHO, Ministry of Health and Family Welfare, including the one column, RCOG and ACOG. So first, including 22 to 34 weeks, yes, there is a grade A recommendations. If you look at the number needed to treat, very low, that is 19, and all bodies, that is Ministry of Health and Family Welfare, WHO, RCOG, and ACOG, all have recommended that we should use uh, uh, universally between 22 to 34 weeks. If the patient is having preterm premature rupture of membrane at risk of preterm birth, yes, the grade of recommendation is A, and all bodies have recommended to use antiretroviral corticosteroids. Between 34 to 36 weeks, that is late preterm, the grades of recommendation is B. If you look at the number needed to treat, that is very high, 55. Ministry of Health and Family Welfare, WHO recommends no to use. RCOG recommends that please explain hazards to the parents, that it can cause hypoglycemia and long-term brain damage, and then you can offer. ACOG has recommended to use before elective cesarean sections. Again, the grade of recommendations B, the number needed to treat to prevent to 1. Neonatal death is 106, very high. Ministry of Health and Family Welfare, WHO recommends no. RCOG again says explain hazards. ACOG recommends no. What about repeat and rescue? Almost all says yes to give, except Ministry of Health and Family Welfare. If you look at the grade of recommendations, grade of recommendation is B. For diabetes mellitus, that is gestational diabetes in the mother, PIH, twins, FGR, grade of recommendation is, D. However, if all these patients are falling between 22 to 34 weeks, we should consider giving steroids. However, in cases of GDM and mother, the risk of hypoglycemia, neonatal hypoglycemia, is 5 times higher, especially in late preterm infants. So please monitor blood glucose very rigorously. What about dexamethasone versus betamethasone acetate and phosphate? Yes, both are equally efficacious. Grade of recommendations B. All bodies have recommended that they both are effective. So I'm ending here. Thank you, all of you, all